everyone, and welcome to this Medscape Oncology program on the intricacies of immunotherapy and COVID-19, strategies to optimize oncology care. I'm Dr. Gary Lyman from the Fred Hutchinson Cancer Research Center and from the University of Washington here in Seattle, Washington. And I have the pleasure of being joined today by my colleague, Kathleen Madden, who's a nurse practitioner at the NYU Langone Perlmutter Cancer Center in New York.
Thank you, Dr. Lyman. Good evening to all of our participants.
So the background of this needs no introduction. As you know, we are continuing to battle this pandemic of the coronavirus and the resulting disease of COVID-19. And those of you caring for cancer patients understand that it is a particular threat to patients with cancer in general, and particularly those on cancer therapies. In February of this year, we identified the first case of COVID-19 in the United States here in Washington State, a patient who had traveled from China. Within a few weeks, we reported the first death from COVID-19, again in Washington State. Data coming out from China, where it had been ravaging for some time, clearly indicated that certain segments of the population, particularly patients whose compromised immune system put them more vulnerable for the pandemic, were particularly at threat for severe disease and even mortality. Well, that's all history now, because we know as of today, there are reported more than 63 million cases of confirmed COVID-19 globally, which is a rate of over 8,000 per million. And in the US alone, we're approaching 14 million cases. In fact, at an even higher rate than the global case rate per million. Unfortunately, the mortality is equally grim. Globally, nearly 1.5 million deaths from COVID-19 since the beginning of the pandemic. And in the US, we are approaching, unfortunately, 250,000 deaths from COVID-19, the highest rate of any country globally. We also know at the moment there are over 100,000 patients who are in critical condition from COVID-19 globally, and over 25,000 in the US. So as this emerged and began to take hold, as I said, it was clear that patients with cancer had particularly increased risk. And many questions have arisen related to what factors in a cancer patient put them at greater risk, and what is the impact of various treatments, including immune checkpoint inhibitors and other immunotherapies. During this program, we hope to explore the role of immune checkpoint inhibitors and discuss what we've learned and what we still need to learn about the optimal management of patients being treated with these therapies. I'll just provide the background that colleagues that I worked with and others here began the discussion in late February about what this all meant for our patients. And in early March, we began brainstorming about how we could collect data rapidly in real time and at scale on cancer patients who were affected by COVID-19. And we launched in mid-March the COVID-19 and Cancer Consortium, CCC-19. But as you see in this chart, within the first 30 days, we had nearly 1,000 patients accrued to a prospective cohort study at nearly 100 institutions across the country, in fact, globally, that participated via the REDCap data platform, which is used by more than 4,000 institutions worldwide. Within a couple more months, we had our first publication in The Lancet. Dr. Nicole Kutter and Dr. Jeremy Warner led the initial effort, developed the platform, but now it is clearly a multi-institutional, huge global effort to capture as much data as rapidly as possible and on cancer patients that are confirmed to be COVID-19 positive. In that first publication, as you see here, we looked at the symptoms that patients were reporting or were being reported in the survey. and they are not unusual. Things like fever, cough, shortness of breath, fatigue. And as you see on the far left, nearly all patients had one or more of these symptoms at the time of presentation. Unfortunately, a lot of these symptoms are not specific to COVID-19, although their frequency and severity may be a clue to what's going on. Within another 2 months at the ASCO meeting and then at the European Society of Medical Oncology meeting, we continued to update the numbers. Here you see data from the ESMO meeting, nearly 3,000 patients in the CCC-19 registry with a mortality rate at this point around 16% of 30-day mortality, with a large proportion of patients ending up in the hospital. A similar study focused on lung cancer, TERAVOLT, was likewise reported at the ASCO virtual meeting this year, 400 patients. And you can see a much higher mortality rate, around 35%, in lung cancer patients, mainly lung cancer patients with confirmed COVID-19 infection. This was conducted worldwide in some 8 different countries. So as time has gone by, this is just an update on the original cohort. Now with more complete data, we see the mortality rate is up closer to 20%, a little bit higher in patients with hematologic malignancies. And to note, for both hematologic malignancies and solid tumors, the mortality rate is somewhat higher in patients on active therapy. It does seem to matter whether the patient is responding or progressing on active therapy, but clearly this mortality rate in the 20 to 25% range is alarming and has led to a lot of the concern over the impact of cancer therapies on risk. An early meta-analysis tried to look at the impact of chemotherapy as well as immunotherapy. 16 studies were looked at. Again, these were early experiences, early cohorts, looking at the impact of chemotherapy or immunotherapy within the last 30 days. And at that time, the conclusion was, yes, there does seem to be an increased risk of mortality in patients who are receiving chemotherapy while infected with COVID-19, and that's shown in the force plot on the left. But there was not a clear signal for immunotherapy. In fact, the 2 studies they reported, one showed higher rate and one showed lower rate, and you see a null effect overall. So clearly very sparse early data that we felt needed to be looked at more carefully. So in the CCC-19 data that was presented at ESMO, the European Society of Medical Oncology meeting in August, you can see here the mortality associated with different types of therapy in the nearly 4,000 patients in the study at that time. Chemotherapy did pose a slight increased risk compared to the untreated population, but it was not dramatic. Immunotherapy, likewise, mainly checkpoint inhibitors by themselves. There wasn't a great increase in risk, but what did stand out and still needs validation or confirmation is patients receiving a combination of chemotherapy and checkpoint inhibitors. That tall bar slightly to the right had a much higher mortality, nearly twice that of patients getting chemotherapy alone or immunotherapy alone. So again, this still needs confirmation, but it does raise concern that these 2 interact or may amplify the effect of each other on the risk associated with COVID-19 in the cancer population. More data has come out of Memorial in New York, and I'll just, this paper here in Nature Medicine from the Memorial team looked at 423 patients that they had seen through August of this year with cancer and COVID-19. I point out only 7% of these patients received an immune checkpoint inhibitor, but in their overall population, after adjusting for other major risk factors, and they're summarized at the bottom, things like age, gender, body mass index, smoking status, cancer stage, and so forth. After adjusting for all those in a multivariable logistic regression analysis, the recent use of an immune checkpoint inhibitor was associated with a little over a doubling of risk of hospitalization and of severe COVID-19. They did not report mortality data, but there did seem to be an influence in their data of immune checkpoint inhibitor therapy recently on the risk of these serious phases of the disease. A subsequent study from Memorial began to look at patients who had received no prior PD-1 therapy, shown in the far left here. These are patients, 69 patients with lung cancer diagnosed with COVID-19. But then they looked at different durations or different intervals since treatment with a PD-1 inhibitor. And it's a little hard to make too much out of the data, except those that received a PD-1 inhibitor did have overall a higher rate of hospitalization, of intubation, and slightly increased risk. The numbers are lower, but it did appear to have a slightly higher rate of mortality. What's interesting, though, the time interval since the receipt of PD-1 inhibitors didn't seem to greatly influence the associated risk. So again, very early data and small numbers, but it continues to beg the question of the impact of immunotherapy in general and immune checkpoint inhibitors on patients with cancer who are affected by COVID-19. I'm going to turn this over now to my partner, Kathy Madden, and let her discuss the immune checkpoint inhibitors and some of the additional data that's come out since then.
Thank you, Dr. Lyman. So the ICIs of interest that we're looking at and primarily discussing are CTLA-4 inhibitors, ipilimumab and tremelimumab, PD-1 inhibitors such as cemiplimab, nivolumab, and pembrolizumab, and PD-L1 inhibitors, atezolizumab, ipilimumab, and durvalumab. Just to do a quick review, that the immune checkpoint inhibitors, they impact the breaking mechanism on T cells. There are multiple checkpoints that do impact acceleration or activation, as well as deceleration or turning off the on button for the T cells. And these particular inhibitors, the CTLA-4, PD-1, PD-L1s, these are all working on the breaking mechanism. So when we exploit those with these antibodies, what we're doing is we're blocking the breaking mechanism, so we're thereby allowing the immune responses to be continued and sustained. Primarily, these are used extensively in solid tumors, but not exclusively. So let's look at the landscapes of potential intersection between immune checkpoint inhibitor therapy and COVID-19 disease in patients with cancer. So some of the main effects with COVID-19 disease worsening in the presence of immune checkpoint therapy, there can be reactivation of the viral epitope specific to the PD-1 and T cells and enhance the tumor necrosis production. So there can be a positive impact and then a consequential or converse negative impact. The positive can be promotion of T cell mediated viral clearance, perhaps a direct antiviral effect, versus a promotion of the Treg activation, which can be an exacerbation of cytokine storm. So this would clearly be a more negative consequential outcome of the immune checkpoint therapy on the COVID-19 viral disease. And some of the main effects, if we look at conversely the alternate consequences of COVID-19 on immune checkpoint inhibitor efficacy, we can see some induced lymphopenia, T cell migration at sites of infection, pro-inflammatory cytokine release. So some of the benefits that we could potentially see is that T cell migration to selected tumor sites, some enhancement, some crosstalk between antigen presenting cells and T cells, and T cell functions enhancing tumor necrosis factor. Conversely, if there can be a depletion of peripheral and pre-exhausted tumor-specific T cells. There can be a down modulation of specific tumor-specific T cell functions, such as IL-10 and IL-6. So thereby, this can worsen the immune checkpoint inhibitor, a pro-inflammatory situation with patients. If we just dial back a second and look at immune checkpoint inhibitors, we understand and know that they can impact any organ system with a pro-inflammatory type of response. There can be auto-antibody responses with the endocrine. There can be attack on muscle, nerve, cell mucosal linings, as well as meningeal and brain tissue. Any organ system can be affected. Usually we'll see the impact on one organ system as a major presentation, and then there could be some maybe subclinical presentations with other organ systems. The main ones that we might typically see are going to be GI, dermatologic, hepatic, pulmonary, endocrine, renal, that we'll see with patients. And again, some of these can be detected by blood work that might be subclinical, and they may not present as much, but they can be very clinically impactful. But again, derm, GI, and respiratory patients will certainly detect, and they can be very impactful. Let's look at the frequency of features reported in immune checkpoint inhibitor treated patients and patients with COVID-19. Some of the overlapping similarities can be fever. Although immune checkpoint inhibitors do not tend to elicit a high percentage of fevers, it can be in that constellation of constitutional symptoms that we can see. However, with COVID-19 patients, that's a pretty high percentage of patients where we can see symptomatology, and it's a fairly extensive list, and there was that nice graph that showed COVID-19 symptoms, and you can see that there's a tremendous overlap. If we look at the column to the right, though, that these are some abnormalities that are a little bit more exclusive to COVID-19 that we don't necessarily dial in and look at with our patients who may be ill in the community, but definitely with our patients who may be sick in the hospital. We're looking at things like D-dimer levels. We can see abnormal liver functions with our patients on immune checkpoint inhibitors, and we may see that to a higher degree, which is not necessarily notated on the slide, but abnormal LFTs can be present with patients who have COVID-19 infections. High CRPs, again, these are not routine tests that we're checking with our immune checkpoint inhibitor patients, but if we do suspect that there's a COVID infection, we'll use that as part of our workup. So again, a lot of investigation that goes into delineating, is there an overlap? Is there concurrence? Is it one versus the other in terms of symptoms? Some additional similarities that definitely overlap can be the fever, dyspnea, cough, conjunctivitis, not inherent with our immune checkpoint inhibitors, but can definitely be part of the COVID-19 profile. GI manifestations can be evident as well, and we know that this can be one of the top issues and one of the earlier on presenting symptoms that can occur with patients who are on immune checkpoint inhibitors. Belching, nausea, and emesis are a little bit more specific to COVID-19, whereas if I needed to add some extras to the irAE diarrhea, patients may feel some bloating or some dyspepsia. Those may be something that could delineate that a little bit. Let's move over to looking at some of the pulmonary presentations and utilizing radiologic imaging. The top line, A through D, is our COVID-19 patients, and E through H, the bottom line, are our immune-related pneumonitis. And if you look A and E, there's a lot of similarity there. Healthy lungs, we really want to see that gray area. That's representative of nice healthy lungs filled with good air exchange. And you can see there's a lot of patchiness going on here. It's not quite as clear. B and F, you can see that there's a little bit of sponginess to it. There's a lot of consolidation and inflammation there. A little bit hard to tell. Looks like there may be some pneumonia starting to organize, especially in B. If we move over to C and G, there's definitely some similarities with some ground glass opacities, those little snowbally features. We call them GGOs for short. So there's some GGOs, there's definitely some organizing pneumonia. And you can really see that the challenges and some of the difficulties of just looking at a radiologic feature and saying, is this COVID? Is this an IRAE? Is this pneumonitis? And it is definitely challenging. And in the final two slides, you can definitely see that there's more pneumonia that's organized there. There's more patchy infiltrates. There's some wall thickening. So again, very challenging and needing to put together the whole host of other presentation symptoms, the patient's history, and where they're at with their treatments. And just moving forward and looking at results from a survey of 104 Italian physicians and how they were looking at their patients. And definitely with the respiratory, we know the respiratory component is significant for COVID-19, but we don't always think of the colitis or the bowel inflammation as being significant, but it's definitely picking up interview factor for physicians and providers looking at patients. Our current and prospective scenarios of ICI therapy in patients with cancer, how do we delineate them? For patients who are ongoing in that left column, who are currently on therapy, it may be if they have mild symptoms, mild viral symptoms, we definitely are going to be recommending molecular screening for them. If they're positive, we're going to delay until they're negative. We know sometimes tests can be positive up to about 8 to 12 weeks after infection has passed. So sometimes there may be some clinical judgment in there. If patient's negative, then we can feel confident about continuing therapy as long as their symptoms don't evolve. If we're looking at new patients, we are generally screening we're screening all of our new patients before they start therapy, especially ICI therapy. If someone is picked up as positive, even if they're asymptomatic, we're going to delay treatment, typically is being recommended. If they're negative, then we're going to go ahead and confidently start therapy. And looking at that balance between harmful and beneficial effects of ICIs, and I really kind of covered this in the other slide, that there can be synergy of the COVID infection with irAEs, and this can be a very harmful outcome for patients where the COVID-19 viral infection can advance quickly and patients can succumb to that or take a longer time to recover. Benefits, there could be continuation of adherence to anti-cancer therapy timeline and reactivation of T-cell immune response, so that could potentially be beneficial. I'm going to turn this back over to Dr. Lyman to walk us through some of the treatment options for patients with COVID-19.
Thank you, Kathy. Wonderful review of the checkpoint inhibitor overlap with COVID-19 symptomatology. So there are, of course, no terribly effective therapies available at this point. Many studies ongoing. There are a large number of clinical trials underway. I think we can say, as shown on this, that the recovery trial has led many institutions, including my own, to utilize high-dose dexamethasone in patients who are developing progressive respiratory symptoms, particularly those on ventilatory support or those requiring increasing oxygen despite not requiring mechanical ventilation at the time. So the recovery trial was a pragmatic trial. There are questions and concerns still about it. Nearly 2,000 patients were excluded because they felt to be unsuitable due to other conditions, and that may have given some bias to the trial. There's no data on oxygen level support, and most of the patients were not on remdesivir, which, as you see also on this slide, has been put forward and is now FDA approved for managing earlier phases of COVID-19 disease. So remdesivir, there are 5 agents actually now in the U.S. that have received emergency use authorization. One of them, hydroxychloroquine, received it back in March, and it was subsequently withdrawn because it does not appear to be effective, and there's even suggestion in some studies it's harmful. Remdesivir received EUA in May by decreasing time to recovery in a randomized controlled trial. Subsequent studies seem to have confirmed some level of benefit, although not yet showing any mortality improvement. And in October, it received FDA approval for treating patients with COVID-19. Convalescent plasma was given emergency use authorization in August and has been used, again, using plasma from recovered patients. And then two recent new drugs, bamlanivimab was given emergency use authorization early last month in November. It's a monoclonal antibody against the spike protein, trying to block the infection from gaining hold. But we've seen very little data there does seem to be some reduction in the severity of the disease, but again, this emergency use authorization may or may not lead to ultimate approval. And then just a couple of weeks ago, baricitinib was given EUA approval on the 19th of November. It's a JAK inhibitor that decreases inflammation. So these are the drugs that are available. Of course, people are using other things, but the one I think we've all gravitated toward in deteriorating patients with acute respiratory distress and requiring mechanical ventilation is steroids. And I do think that's made a considerable difference. And now remdesivir for earlier phase patients who are particularly vulnerable, and I think cancer patients generally will fall into that territory. I think we can just talk in terms of the effects of steroids on immune checkpoint blockade in patients, and raise the question: is there an interaction or interference between steroid use? Of course, could complicate the course of treatment in patients on immune checkpoint inhibitors. Kathy, I might just ask you.
Sure. Grading guides our management. So with irAEs, we are not throwing steroids at lower grading irAEs. So we're not going to start off with high-dose steroids when somebody has a grade 2 or grade 3. We're going to dose that accordingly. And we're keeping very close track of these patients. Anybody who has a suspected viral illness or irAE that could potentially be related to treatment, these are patients that we're having very close contact with, sometimes twice a day. One, we want to keep them home as best as possible and keep them safe. And we don't want to rush to use steroids when maybe 24 hours could declare itself. And not everybody who has viral symptoms has COVID. So, sometimes we just really need to keep in close touch with them.
Yeah, I might just ask also, while we're on it, remdesivir, how frequently is that being used in those patients who aren't yet candidates for steroids, perhaps?
We have not moved to use remdesivir in the outpatient setting. That's primarily been reserved for our inpatients.
Yes, well, same year.
Right.
So there are treatment dilemmas which you've highlighted and we've talked about earlier on the use of immune checkpoint inhibitors. Still a lot of unanswered questions. What to do in patients who are newly diagnosed or who have already been on immune checkpoint inhibitors as part of their cancer therapy, and then they come in with a positive PCR for the coronavirus. How do you weigh the risk? Do you just consider the patient's disease status, the other therapies they're on? What kind of considerations you take into deciding how to manage those patients and whether to delay or stop their therapy?
Sure. Well, in New York City, we never closed our doors. So our doors stayed open throughout the height of everything during the most uncertain times. We were conservative at first about starting new patients. A lot of those patients had delays to getting to surgery, so they weren't getting final staging. But now that we're really back on track, we have not really delayed any of our adjuvant patients, our neoadjuvant patients, or any of our new metastatic patients. We definitely have candid discussions with them about safety measures because this is COVID has moved so significantly to the community setting. It's really about safety and precautions and interactions within the community, and that these patients can be at higher risk and more vulnerable, and that they do need to take those safety precautions.
Yeah, I think that pretty well summarizes what most major institutions across the country have done. Early on, of course, there was a panic and a tendency maybe to try to delay. We didn't realize this was going to go on and still be here at the end of the year, but obviously it became quite evident during the summer, even before that, that these patients needed treatment and we needed to proceed with treatment, but with appropriate safety precautions. And I think that seems to be quite successful in most centers.
Absolutely.
So any thoughts on altering dosing or schedule, or you just pretty much proceed with the regimen as tested in controlled trials?
The only time we don't alter our doses, especially with ICIs. If somebody has chemotherapy in their regimen, that may be a consideration. But generally, patients are going on as scheduled. Only interruptions to the scheduling is if a suspected irAE or suspected viral illness that we can't quite put our finger down on and hasn't quite declared itself. I would err on the side of caution to be a little bit more conservative, maybe put them off for a week, reevaluate, and again, be in close contact with them.
The use of telehealth, I think, has become quite generalized, and maybe a side effect of the COVID-19 pandemic, that we're going to be doing more of this even after the vaccines are widely distributed for the convenience of patients and preventing other kind of health issues. Supportive care, different guidelines have updated their supportive care to be perhaps a bit more aggressive, particularly around myelosuppressive therapies, use of growth factors, and so forth, both with the idea of reducing the risk of other infectious complications, but also keeping the patient as distant from the healthcare setting and hospitalization as possible, and not to overlap with the pressure that COVID-19 has brought to bear. In talking to patients, Kathy, any special messages do you discuss? I'm thinking mostly of the patient who comes in, maybe tests negative, but it's out there, and you're putting them on a therapy that may pose some increased risk to them. Any special education or message that you can convey to patients who you're starting therapy on?
I think we really hit home with just call us if anything changes. Sit and go through all of the same potential irAEs. And oftentimes patients are savvy enough, they're familiar with what to look for COVID, and that always comes up as part of the conversation. The main message and take home and homework is, I'm giving you all of this information to be aware of, and so you can be informed and knowledgeable as to know when to call us. And I don't want you to get afraid or hesitant, just call. And if anything is different, call. And I always let them know they're not alone, and that this is a partnership, and that we're doing this together, and I don't expect them to have to figure this out alone at home on their own.
Great, thank you. So just listed here are some of the guidelines that are out there for managing COVID-19 in the cancer setting. You're probably familiar with these, but I would just highlight ESMO, NCCN, ASCO, ONS. All of these are useful sources of guidance that have been updated right up to the present time. So vaccines, of course, today the CDC is just beginning its process of deciding a prioritization of the first couple of vaccines once they're approved by the FDA. So I would say just watch the evening news over the next few days, and maybe you'll learn as much as we know about who's going to get the vaccine and when. These are new technologies, at least the first two vaccines that have submitted for emergency use authorization to the FDA. So there are some unknowns here, but the data on tens of thousands of patients does seem to attest to their efficacy and safety, and it's pretty exciting in such a short time that we are even talking about distributing vaccines at this time. I'll just conclude by saying, as we've said from the beginning, cancer patients are at high increased risk for SARS-CoV-2 and COVID-19 infection. Patients with cancer on active treatment are probably at somewhat greater risk, but again, with proper safety precautions, standard therapy in patients who are at risk from their cancer, which is almost all the patients we decide to treat, should proceed with therapy with proper education, obviously with shared decision-making and aggressive supportive care. The greatest risk from cancer treatment seems to be in those who are progressing on the treatment. And so that's an interaction between the cancer itself and the infection. Those patients may be at the greatest risk of hospitalization and early mortality. Patients receiving chemotherapy or immune checkpoint inhibitors should be advised that there is some increased risk, and receiving both of them, again, some data suggesting the combination may pose a somewhat higher risk, but that needs to be confirmed. So overall, I think we can say appropriate timing and type of cancer therapy, including immune checkpoint inhibitors, while they do pose some risk, one has to take into account the local regional spread of the disease, the safety precautions in place at your institution, and then have a discussion, an honest, frank discussion. It is a partnership between the provider and the patient to get the patient through this situation and beyond their disease and their pandemic. I'd like to give many thanks to my co-host, Kathleen Madden, and thank you all for participating in this program. You're so welcome. And to all of you, stay safe, protect yourself and your family and your patients. And if you want to receive credit, you see how to access the link on the screen to get your CME or CEU credit. Thank you all for joining.